Ovarian cancer or carcinoma accounts for a quarter of all genital tract cancer, but is responsible for more than half the death, primarily due to its late presentation. The first sentence itself is so important here. It is not the most common genital tract cancer. It accounts for only a quarter of all genital tract cancer, means 25%, maybe quarter, okay, 1/4. But having said that, it is the most lethal type of cancer because of its late presentation. By the time the lady comes with ascites, it is already too late. It is already late. Already metastases have occurred and prognosis is extremely poor. Most of them are adenocarcinoma. They are gland forming tumor, but okay, they may be dysgerminoma or granulosa cell tumor, or they may be metastatic tumor. Now, if I go back to the classification, again the same classification will come into picture. I will revise this so many times in this topic. These are epithelial cell tumor, germ cell tumor, sex cord, okay, stromal cell tumor, and metastatic tumor. These are 4 big headings, either for benign or malignant. Never forget this. Absolutely important question from the exam point of view. Among them, epithelial cell tumor or surface epithelial tumors are the most common one. Okay, then germ cell tumor, then sex cord stromal tumor, and finally metastatic one. So they can be anything, but mostly adenocarcinoma are the commonest one because surface epithelial tumor are the commonest. About the risk factors of ovarian cancer. Now, I was describing what do you mean by relative risk. Now, listen properly. This is a very important concept for you, which is from the epidemiology, from preventive and social medicine. Yes? Yes, yes. Are you saying anything? Now, see there. What is relative risk? Now, relative risk means what is the exposure here? We need exposure to explain the relative risk. And this exposure is a family history here. So if a lady is having family history like this, which is mentioned here, then the risk of having ovarian cancer is 6 times than the lady who doesn't have history of family cancer or ovarian cancer in the family. That is the meaning. Okay. And if a sister is having ovarian cancer, then the relative risk in that lady is 3.8, means 3.8 times more chance of having ovarian cancer than the lady who doesn't have that type of risk, that type of history. Another important risk factor which we are going to talk is the presence of gene which are known as BRCA1 and BRCA2 gene. Now, you can also call them breast cancer gene 1 and 2. Okay. Now, the name is breast cancer gene, but they are also associated with ovarian and other type of cancers. So there is a data for you. Women with BRCA1 gene have a 50% lifetime risk of developing ovarian cancer, whereas women who is carrying BRCA2 gene have a 30% lifetime risk of developing ovarian cancer. So what is the knowledge we gain from here? During investigation, if somebody is carrying this particular gene, then it is better to remove, okay, the ovaries. It is better. It is a big decision, but a proper counseling has to be given to that person, to that lady, I mean, and then it is her decision what she wants, because there is a high chance of developing cancer later on. But trust me, this is a big decision, and so many of them, they see, let's wait and watch what will happen. Let's see, like that. Let's move on. Now, regarding the family history, There are three important things here. Okay, let me highlight them once again. There are three familial ovarian cancer syndrome which exist in the family. Number one is the site-specific ovarian cancer syndrome. The site-specific ovarian cancer syndrome. Here, only ovarian cancer is seen, and it accounts for 10 to 15% of the hereditary ovarian cancer. The second one is hereditary breast ovarian cancer syndrome, like which is associated with BRCA gene. It is associated with 65 to 75% of hereditary ovarian cancer. And the third one is called hereditary non-polyposis colorectal cancer syndrome. Okay, we have discussed this before. Hereditary non-polyposis colorectal cancer syndrome, but the name is colorectal cancer. Any type of cancer can occur in this case. Okay. This is a important condition. So the affected individual may have colon cancer, endometrial cancer, breast cancer, ovarian cancer, or any other type of epithelial cancer. So these three, are the familial ovarian cancer syndrome. Means they may run in the family. Now, what are the other risk factors apart from them? Prolonged periods of uninterrupted ovulation is another one. Prolonged periods of uninterrupted ovulation. And that can be seen in nulliparity or first child after the age of 35. Now, look here carefully. Okay, try to understand the point here. Okay, prolonged periods of uninterrupted ovulation means ovulation is happening there. Ovulation is going on, but she has never, bear any child. They never become pregnant. This is the meaning. So nulliparity and first child after the age of 35, or she has been pregnant after a long time. Okay, 35 years is a long time. She never become pregnant before. So this is called uninterrupted ovulation. This has, this is considered as one of the risk factors for ovarian cancer development. In comparison, endometrial cancer occurs because of uninterrupted estrogen exposure. Okay, now what does that mean? There is a huge difference between that. In that condition, probably there is no ovulation itself, no ovulation. Okay, so this is a difference. So that's what I mean. Try to understand this. These are not the same condition here. They're different. Another is a late age of menopause. Again, okay, late age of menopause, and especially if she has not bear any child. That's the important point. And white race. In comparison, white race ladies or Caucasian, I should say, have more chance of development of ovarian cancer. This is a racial difference. Now, other risk factors are dietary factors also. Okay, so there is one hypothesis or presumption that diets which are high in saturated animal fat seems to confer an increased risk of ovarian cancer by some unknown mechanism. And one of the important points to prove that is Japanese women who move to the United States have an increased ovarian cancer risk. Okay, look at the important difference of the food they have. Though this is not entirely true, the people who are living in the United States, all of them, they don't eat this type of burger every day. But having said that, this is one of the main food there, isn't it? We believe people eat this type of food there. And sushi, these are the important food in Japan. Okay, these are much healthier than this burger. So a lady who is in Japan probably having this type of food, so the chances of ovarian cancer is not that high. But when the same lady moves to the United States, now she switched to this type of food probably, so the cancer risk is high. This is one of the assumptions. Now, there are certain protective factors against ovarian cancer development, and those are oral contraceptive pills. These oral contraceptive pills are protective because they suppress ovulation. And how they suppress ovulation? Yes, how? Anyone?
Sir, oral contraceptive pills mainly contains the estrogen and progesterone. And estrogen, sir, it's a negative inhibition on the anterior pituitary gland. Sir, there is no release of the FSH and LH, and there is no follicular production, and there is no further ovulation occur.
Excellent. Very good explanation you have given. Exactly the same mechanism occurs here. If somebody is taking oral contraceptive pill, it has got estrogen as well as progesterone, especially in the combined oral contraceptive pill, and that will give negative feedback to the anterior pituitary, so that the gonadotropins which are released from there are inhibited. There is very decreased or reduced level of FSH and LH. So without them, there is no chance of ovulation. Okay, so this is the mechanism here. Very good. So there is a significant reduction in risk even after 1 year of use, and 5 years of use cuts the risk nearly in half. So this is a very important data. But having said that, so many of them, they don't like to take oral contraceptive pills as a family planning method because it has a lot of other complication. Multiparity is a protective factor, because the more children the lady have, the more decreased risk of ovarian cancer development. Okay, this is a important point. Lactation, okay, again associated with the same type of thing. A prior history of infection with the mumps virus may have a protective effect. Now we really do not know what's the mechanism here, but mumps virus can lead to gonadal infection in male orchitis, in female euphoritis, and we believe it damages the gonad, and sometimes that person may become sterile also after getting infection from the mumps. So probably because of the damage it has done to the gonad, there is less chance of ovarian cancer. On the other hand, retinoids or vitamin A derivative and vitamin D, they are considered preventive agent for ovarian cancer. And I want to add one more thing here. These days, there is a very important role of antioxidant. If we take enough amount of antioxidant in our diet, they can prevent from the development of any type of cancer, anywhere on the body. So can you give me some of the example of antioxidants? Yes.
Vitamin C, glutathione.
Yes, good. Vitamin C, glutathione, even vitamin A. Okay, vitamin A is also considered that, and vitamin E. So vitamin A, vitamin C, vitamin E, and glutathione. Very good, excellent. And all of these are present in abundant amount in fruits and vegetable, green leafy vegetable and fruits. Now that's why, okay, any doctor advises you to take good amount of fruits and vegetables in your diet. Do not ignore them. I have seen so many people who doesn't like fruit at all. They don't like any type of fruits. Okay, and vegetable as well. They mainly take meat. Meat alone is not enough. We need antioxidant in our diet. So balanced food is so much necessary to avoid the development of cancer these days. Now, after talking this risk factor, let's move on. These are the major histopathological categories of ovarian cancer, and this is just a revision for us. Now, let's revise once again, because this is absolutely important question in the Viva exam or even in theory paper. Now, let me go through it again. These are epithelial ovarian cancer or tumor, which are the most common one, followed by germ cell tumor, sex cord and stromal tumor, and finally metastatic. So among the epithelial, we have got serous, okay, serous cystadenocarcinoma, mucinous cystadenocarcinoma, endometrioid carcinoma, clear cell carcinoma, Brenner cell carcinoma, and undifferentiated means we do not know what type of cells are there exactly. Okay, so these are some of the example. This Brenner cell has got transitional epithelium, so it's a type of transitional cell carcinoma also. So Brenner, remember the name. After that, germ cell, tumors. These are dysgerminoma. Okay, endodermal sinus tumor, also known as yolk sac carcinoma. Okay, yolk sac carcinoma or endodermal sinus tumor, teratoma. And remember, we are talking about ovarian cancer now. So it is immature type of, cancer, immature type of teratoma. Okay, very, very rarely mature teratoma may complicate into the malignancy, but that's absolutely rare. Embryonal carcinoma, choriocarcinoma, gonadoblastoma, mixed germ cell when they are having more than one tissues, and polyembryoma. Okay, embryoma. Okay, M, it should be M. So these are some of the important one. You don't need to remember all of them. Just remember dysgerminoma, okay, immature type of teratoma, a choriocarcinoma, and embryonal carcinoma. These are quite catchy names. The third variety, sex cord and stromal tumor. They are granulosa cell tumor. Okay, then fibroma, thecoma, certainly Leydig cell, and one of the interesting type is called gynandroblastoma. Now see that GYN, gynecology, and andro means androgen. Now if you analyze it, you got the meaning here. This type of malignancy contains both type of cells. Okay, so both type of cells means estrogen producing cells are also there, androgen producing cells are also there. So probably granulosa cell, or the cells, which results in the production of estrogen. Importantly, these are the granulosa cells, they are also present. And there's a Leydig cell, certainly Leydig cell are also present. So this is a mixed type of tumor, gynandroblastoma. And the last one, any type of metastasis to the ovary from other site, like breast cancer, colon cancer, stomach, endometrium, as well as lymphoma. One of the example is called Krukenberg tumor. If a transperitoneal type of metastasis occur on the surface of the ovary, that is known as Krukenberg tumor, which is very commonly occurring from the GI malignancy. Now, a bit of schematic diagram. See there. But once you already saw that classification, it is nothing actually. This is the epithelial cell tumor, which arises from the surface layer of the ovary, germ cell tumor, stromal cell tumor, okay, and some metastasis which is coming from outside. Now, again, the same thing is shown here: surface epithelial tumor, okay, germ cell tumor, and sex cord stroma cell tumor, and these are the different example for you. Now, let's move on. Now, let's do the staging of ovarian cancer. You all know staging means how far the cancer has spread from the site of origin. International Federation of Gynecology and Obstetrics, this is known as FIGO staging. Okay, the same staging we have discussed for carcinoma cervix and endometrial carcinoma also. Stage 1 means growth which is limited to the ovary. Stage 1A means one ovary is involved, there is no ascites, and capsule is intact, means capsule is not invaded. Stage 1B, both ovaries are involved now. Again, there is no ascites and capsule is still intact. And stage C, okay, 1C, I mean, capsule is ruptured, means capsule is invaded, okay. Positive peritoneal washing means peritoneum is also involved now, or malignant type of ascites. Malignant ascites means the peritoneum is affected or infiltrated by the malignant cells. As a result of that, ascites is formed. So this is malignant type of ascites. When we aspirate some of the peritoneal fluid and send for cytology, they may detect malignant cells there. Now, stage 2, ovarian growth with pelvic extension. 2A, extension to uterus or tube, fallopian tube. 2B, to other pelvic organ like bladder or rectum. And 2C, extension plus finding as for 1C. Okay, means a capsule is involved, a peritoneal washing is positive, or there is presence of malignant ascites. You need to remember this, just develop a concept. I've included some of the pictures from the internet to make it easier for you. Stage 3, see there? Wait. Let's see here. Stage 3, tumor outside the pelvis or with positive lymph node. Now, again, stage 3A is microscopic seeding outside true pelvis. It has gone into the abdominal cavity. 2B, gross deposit less than or equal to 2 centimeter. And 3C, sorry, gross deposit greater than 2 centimeter or positive lymph node. So nodal involvement is important point here, and tumor has clearly gone outside the pelvis. Okay, pelvis means pelvic cavity. Outside means probably it has gone up towards the abdominal cavity now. And stage 4 is the most advanced type. Is a distant organ involvement, including pleural space and liver parenchyma. So lung and liver metastasis are important part of stage 4 disease. Now look here. Okay, this is stage 1A. One ovary is involved. So it is shown here in the schematic diagram. See this? There is a tumor, okay, in the ovary, and this tumor has not, invaded the capsule. This is encapsulated tumor. Capsule is still intact. Another ovary is fine. Only tumor on one side. See this? Stage 2, sorry, 1B, both ovaries are involved. There's tumor on either side, you can see, but they are nicely encapsulated again. Now, 1C, okay, 1C means now the tumor has invaded the capsule. Capsule is breached or infiltrated or invaded, and some of the tumor cells have also escaped into the peritoneal cavity, okay, or they have caused the malignant ascites. So this is malignant cells in the peritoneal washing. Stage 1C. 2, okay, extension to the uterus or fallopian tube is 2A. See here, there is a uterus, and these are the fallopian tube. There is ovary, so there is a tumor. Okay, this tumor has already, infiltrated the fallopian tube here. This is 2A. Now, 2B. Okay, there is 2B, the pelvic tissue. See this? The tumor has, involved the other pelvic organ, okay, or pelvic tissue. And 2C. See there? Ovarian surface tumor, ruptured capsule, malignant ascites, or peritoneal cytology positive for malignant cells, along with pelvic involvement. Pelvic involvement is a very important point here. Along with that, whatever we discuss in 1C will come here again. Means there is ascites. Now, what is 3A? Abdominal peritoneal surface with microscopic metastasis, okay, or nodal involvement. See there, there's extensive involvement now, and this is the a peritoneum which is shown, okay, because these GI organs are covered by peritoneum. So this is a peritoneal seeding, okay. Peritoneum is infiltrated, and if we take a biopsy from a peritoneum, or if laparoscopic examination is done in that peritoneum, they can see metastasis there. 3B, tumor metastasis have already occurred there, but the size is important here. Okay. 3C, it is more than 2 centimeters. And lastly, stage 4, the distant metastasis. Look at the different site for distant metastasis: lung, liver, bone, brain. Any sites or any organ can be involved at the stage 4. So we may have malignant type of pleural effusion. See here, malignant pleural effusion means there is collection of fluid in the pleural cavity, and when we aspirate that fluid out and send for the lab analysis, there are presence of malignant cells. Pulmonary parenchymal metastasis would be there. Any type of metastasis in the lung parenchyma is called cannonball appearance, because they just look like a rounded ball like appearance, cannonball appearance in the X-ray. Liver or splenic parenchymal metastasis, and metastasis the supraclavicular lymph node. Now tell me once again, what is this sign called? Left supraclavicular lymph node is involved. What is this sign? Very good. Virchow node. Yes. Or Troisier sign. Virchow node or Troisier sign. Excellent. So this is repeatedly coming, isn't it? So important question from the exam point of view. So this is how we do staging in the ovarian cancer. Now let's move further. Let's talk about some other aspects of this big topic. How we do screening of the lady, okay, who are at risk. Unfortunately, there are no good screening method for ovarian cancer at present, but we can nevertheless do some of the tests, okay, like this. Must use a combination of physical exam, CA-125 level, and transvaginal sonogram. Transvaginal sonogram means ultrasound which is done through the transvaginal route. No role of routine screening in general population. How many ladies you routinely screen? Isn't it? It's impossible. But whom to screen? If there are certain risk factors, then we have to screen them. Okay, we talked about that. Remember, the most important one of them is a family history. If a lady inside the family develops ovarian cancer, then all other ladies who are in that family should go for the screening one. And that screening is done by this different method like CA-125 and transvaginal sonogram. Okay, and of course, history and physical examination has to be taken. And if BRCA mutation or BRCA gene they are carrying, then also we do the same thing, because there is a chance of development of ovarian cancer. Not only ovarian, breast cancer can also be there. Now, what is the prognosis? See there. Now, the prognosis for patient with ovarian cancer is primarily related to the stage of disease. In which stage we have diagnosed it, in which stage the ladies have presented to the hospital, it depends on that. Germ cell tumor are associated with a better 5-year survival rate than epithelial ovarian neoplasm. And one of the important germ cell tumor is dysgerminoma. It has a 5-year survival rate near to 95%. That is excellent. Okay, this is dysgerminoma. This is radiosensitive tumor. So radiation therapy is really helpful here. Immature teratoma. Now, this is a teratoma which is a malignant type, are associated with 5-year survival rate of 70 to 80%. It's still good. Up to 80% is considered good one. Endodermal sinus tumor is associated with a 5-year survival rate of 60 to 70%. It's a bit dropping now. Okay, and embryonal carcinoma, choriocarcinoma, and polyembryoma. All of these are different types of germ cell tumor, are very rare lesion, and it's difficult to assess the 5-year survival estimate. Means enough sample size is not there, for us to study these things. Whereas epithelial ovarian neoplasm of low malignancy potential are characterized by a 5-year survival rate of 95%. So these are also good if we detect them quite early. Now, a very familiar type of discussion with you or for you, that is spread. of the ovarian cancer, how they spread to the nearby structures, and how they go very far away from the ovaries. One is direct invasion. Direct invasion. It gain attachment to the adjoining or adjacent structure such as the uterus, broad ligament, omentum, or even intestine. This is direct invasion. This is the hallmark of malignancy. Any type of malignancy, they have got direct invading property. Peritoneal seeding across the abdominal cavity, very, very important way of spread. How do we diagnose it? There are few clinical features. One is ascites. Whenever peritoneum is affected, ascites is there. This is known as malignant type of ascites. Large amount of fluid is collected in the peritoneal cavity, and even if we tap it out, within few days the fluid will recollect again, because the primary disease is still there. So that is just a symptomatic treatment, even if we remove the fluid out. Another is small nodule or metastatic deposit on the peritoneum, which can be seen by certain investigation like laparoscopy. Another way is a lymphatic spread. It may reach the drainage lymph node first. It may reach to the para-aortic group of lymph node, and it may even reach to the left supraclavicular lymph node. This is called Virchow's node. Hematogenous spread occurs uncommonly and late. And if a hematogenous spread occurs, it may go anywhere. It may go very far also, like in liver, lung, brain, and bone. Liver, lung, brain, bone means throughout the body. Now, after discussing all these things, let's enter into the very important part of this topic, that are symptoms and signs. Okay, as an MBBS student, you should remember this, because without this, you cannot diagnose ovarian cancer. Means if you don't know how they present, how you diagnose, isn't it? So this is like an entry door for us. So common symptoms in case of ovarian cancer are pain. Pain is more common than in benign tumor. And most commonly, it results from a rapidly enlarging malignant lesion. Now, it is a rapidly enlarging lesion. So it may give pressure to the surrounding area. Some nerve trunk, some neurons may be compressed, resulting in pain. Another cause of pain, some hemorrhage may occur inside the mass that can even distend the mass, that can cause pain. Sometimes twisting may occur there, torsion may occur there. So all of these are responsible for pain. Second is abdominal girth, similar type of description like benign ovarian tumor. It may increase significantly due to tumor itself or because of malignant ascites. This is known as malignant ascites, already talked about. Okay, one small point here. If I draw that fluid and send to the lab, what type of ascites it would be? Is it transudate or exudate?
Exudate.
Exudate. Excellent. This is exudative ascites. Very good. This is exudative ascites. Okay, don't forget. Though this is not a feature of inflammation, infection here. Inflammation, of course, occurs. So it is exudative type of ascites. A large abdominal mass in a cachectic patient may be a striking sign of a malignant lesion. Now, cachectic means severe weight loss. The person looks like she has only skin and bone, no muscle mass on her body. Cachexia. There are so many differential diagnoses of cachexia. One of them is cancer. Cancer, any cancer, in the late stage, that may result in severe weight loss. Now, if a lady comes to us with a large abdominal mass, that abdominal mass may be because of tumor itself or because of ascites. And if she is very thin, think about ovarian cancer as one of the differential diagnoses. You may be wrong, okay? But we don't care whether we are wrong or not during that stage, because we still have got investigation in our hand. but this is the way to think. An enlarged abdomen may cause early satiety, similar to the benign ovarian tumor because of the pressure to the stomach. So some other symptoms are pressure effect. Okay, again, same type of clinical features. Large tumor in the rectovaginal pouch may displace other pelvic structure upward, so it may disturb the urethra and producing urinary retention. And rupture can also occur, especially in case of mucinous cyst adenocarcinoma. It has got a lot of mucinous material, so when it ruptures, it gives rise to pseudomyxoma peritonei. Pseudomyxoma peritonei. Very important MCQ question from the exam point of view. They may give this question to you and give 4 options, and which cancer usually causes pseudomyxoma peritonei, like that. You always go for mucinous cyst adenocarcinoma. Now, all of you, please focus on this slide. These are the symptoms of ovarian cancer. So see here, there may be persistent bloating. Okay, persistent bloating. Now, bloating is a distension of the intestine or even stomach because of the pressure. Because the pressure of that enlarging mass on the GI tract, the gas may be accumulated there. Feeling full quickly, okay, because of the decreased stomach size and because of the pressure to the GI tract also. So similar type of things. Loss of appetite. This is the overall, symptom of cancer. Any cancer in the body, okay, the person will lose appetite. Anorexia will be there. Urinary urgency or urinary retention, both can be there. Urgency as well as retention. It depends on how big is the mass. Fatigue because of anemia. Anemia is common in any malignancy. Unexplained weight loss. Very important feature because many of them are asymptomatic in the beginning. So that lady may just be, anorexic and she's having constant type of weight loss. Think about malignancy and try to search for it. Try to find it, where is it? By taking good history, physical examination, and investigation again. Another may be pelvic or stomach pain. So these are some of the common symptoms of ovarian cancer. Now, on the other hand, what are the signs? See there. Some important signs of ovarian cancer can be as follows, but may be difficult to detect early. They may be difficult to detect early because most of them come a bit late and many of them are asymptomatic in the beginning and later on only present. Persistent or progressive ovarian enlargement in a young woman, okay, can be a feature of ovarian cancer. But at the same time, they are also seen in some of the functional cysts. That's why benign ovarian tumor and malignant ovarian tumor are difficult to distinguish sometimes. Okay, that's why that sentence is given there. Functional cysts are rarely larger than 8 centimeter in diameter and they tend to regress during the subsequent menstrual cycle. Whereas if it is ovarian cancer, it doesn't regress. It keep on increasing in size. So this is one important difference. Palpable ovaries in a post-menopausal woman. Now see there, post-menopausal, there is no more menstruation. There is no function of the ovary to be very precise. So expect the ovaries to be atrophic 2 years post-menstruation. But if ovaries are still palpable, probably there is a tumor growing there. And after the post-menopausal, we are afraid that tumor may be malignant. Irregular, nodular, or partially solid mass, usually bilateral and fixed, can be a feature of malignancy. And ascites, okay, ascites are an important feature of malignancy. Now, we are talking about the clinical features of ovarian cancer, and these are the different signs if ovarian cancer is spread to other organ, and they include, see there, constipation, if it has invaded the colon, or if it has compressed the colon and it leads to bowel obstruction, it leads to constipation. Especially sigmoid colon is compressed from the left side and other from the right. Hydronephrosis from ureteric obstruction. Hydronephrosis, you all know the meaning of hydronephrosis. This is also known as obstructive uropathy. When there is a chronic obstruction of the ureter, then ureter is dilated with lots of urine collection, which is known as hydronephrosis. The kidney is damaged because of back pressure development. It is one of the cause of renal failure. Uterine or vaginal bleeding may occur from erosion from the local invasion. Lower limb edema may occur from thrombosis of the inferior vena cava or an iliac vein. Sometimes, those veins can be infiltrated by a tumor thrombosis, and even pleural effusion can occur from distant metastasis. If the malignant cells reaches the lung or the pleural cavity, it can happen like that. Okay, so these are spread to the other organ. In a different types of clinical manifestation, which should take history. Then, if these things are present, then we can suspect they may be caused by ovarian cancer. Now, sometime there may be paraneoplastic syndrome development. Paraneoplastic syndrome development. Now, there are some important terms here. Okay, have a look. There may be hypercalcemia in the patient. Now, hypercalcemia is associated with clear cell tumor because they may produce PTH-like substance, parathyroid hormone-like substance, which may act on the bone and it may resorb the bone. And by doing so, calcium is increased in the blood. Hypercalcemia. Okay. Another one is cerebellar degeneration. What is the function of cerebellum? What's the function?
Positioning.
Maintenance of the gait, balance.
Good. Maintenance of the gait and balance. Excellent. Yes, that is the function. Now see here, if these Purkinje fibers are present inside the cerebellum, okay, these are important fibers or cells. Now, there's antibody produced by the malignancy against these Purkinje cells of the cerebellum, which results in cerebellar dysfunction. So the lady who is having ovarian malignancy can, have the imbalance and cannot, maintain the gait. That can be there, but it is quite rare. Another is seborrheic keratosis. Now, seborrheic keratosis in a patient with ovarian malignancy is known as laser Trellard sign. Laser Trellard sign. So what is this? This is a rare skin condition which is characterized by the sudden appearance of seborrheic keratosis here that rapidly increase in number and size within the weeks to months. Now, the seborrheic keratosis are a little bit of brownish to black freckles or patches present on the skin. Okay, brownish to black freckles or patches present on the skin. And if they suddenly appear in a large number in a lady who is having all other features of ovarian malignancy, then it may be considered as a paraneoplastic syndrome. But the exact reason why it is appearing there is very poorly understood. Let's move on. Now, what are the other investigation we like to do? Another is serum tumor marker. Now, this is an important part of this lecture because a lot of questions can be asked from here. Okay, so please pay attention. One of the most important serum tumor markers is CA125. Okay, carcinoma antigen 125. So if it is 35 international unit per ml or greater than that, arrange an ultrasound scan of the abdomen and pelvis just to see the mass there. just to see the growth there. So it indirectly tells us ovarian cancer is there. Okay, the high possibility is there, but it is never specific of ovarian cancer only. Others are alpha fetoprotein and beta human chorionic gonadotrophin, or beta HCG. They are produced by germ cell tumor. Now there is a a table which I have collected. And that table is clearly telling you which are those ovarian cancer and which are the tumor marker. Okay, so let's go through that. Let's go through this first, and then I'll move on there. CA125 is mainly seen as a tumor marker of epithelial ovarian cancer. And one of the good example, or the most common type of epithelial ovarian cancer, is serous cyst adenocarcinoma. Okay, so epithelial ovarian cancer, serous cyst adenocarcinoma in CA125. Now, CA99, carbohydrate antigen 99, is mainly seen in mucinous cyst adenocarcinoma. This is again epithelial ovarian cancer, but it's a mucinous type. Beta HCG is mainly produced by choriocarcinoma and dysgerminoma. Choriocarcinoma and dysgerminoma. Choriocarcinoma is the easy name for you to remember. Alpha fetoprotein, okay, is yolk sac tumor and teratoma. Yolk sac tumor, also known as endodermal sinus tumor. Placental alkaline phosphatase is important one in dysgerminoma. We already talked about this in the last class. Dysgerminoma, placental alkaline phosphatase. Remember, alkaline phosphatase may be coming from so many other sources, but this time it is coming from the placental tissue. This is a malignancy. Placental tissue is present here inside the tumor. Now look at this table here, okay, and repeat it until and unless you are quite confident regarding the different example. CA125, so epithelial ovarian cancer, okay, especially serous adenocarcinoma. Carcinoembryonic antigen, okay, or carbohydrate antigen 99, mucinous ovarian cancer. HCG, or you can call it beta HCG, human chorionic gonadotrophin, embryonal carcinoma, and choriocarcinoma. Inhibin A or inhibin B is produced by granulosa cell tumor. Now, inhibin, okay, is one of the hormone which is produced by, even by testes or ovary both, and this will give negative feedback to the pituitary for the secretion of gonadotropin. So this is maintaining the negative balance there, okay, and maintaining the negative feedback. This is a normal case I'm talking about, but even a malignancy like granular cell tumor may produce them. So this can be utilized as a tumor marker. Lactate dehydrogenase is another one, okay, lactate dehydrogenase, sorry. This is a very non-specific type of, enzyme, and dysgerminoma may be having elevation of this. And alpha fetoprotein is seen in endodermal sinus tumor or yolk sac tumor. So a lot of MCQ question can be asked from this important example.
Excuse me, sir.
Yes, please.
Sir, this lactate dehydrogenase, like, sir, it is present in almost all living. So for example, sir, if it's any type of cancer, sir, there is the breakdown cell, or sir, there is death. So this lactate dehydrogenase will be increased. So, like, sir, on the basis of this, sir, we cannot, I think, sir, cannot diagnose this germinoma. So, sir, sir, how it is specific to it mainly, sir?
That's what I just told you. That's what I told you. It is non-specific. It is seen in so many other cancers also, but we don't only rely on this, we rely on how it presents. What are the important symptoms? What are the signs? We have already that information with us. We are going to do certain other tests also. In the presence of all those, if lactate dehydrogenase is high, then what is the source? You can think. Okay, the same patient may not be having other cancer at the same time, isn't it? So this is the way we do clinical diagnosis. Okay, but if they only give increased lactate dehydrogenase and nothing else, then of course you are right. It can be anything. Actually it can be hemolytic anemia also. Okay, so that is a different thing.
Yes.
Now let's talk about CA 125 or carcinoma antigen 125 here. So this is the sensitivity, specificity, okay, positive predictive value and negative predictive value regarding the diagnosis of ovarian cancer. Okay, sensitivity 61 to 90%, specificity 71 to 93%, positive predictive value 35 to 91%, and negative predictive value is also high. So this is one of the good tumor marker which is used for the diagnosis. And I'm sure you all know the meaning of these terms because these are very special terms in epidemiology. Were you taught about this or not? Not now, right? Probably this comes in community medicine. So community medicine will be taught from 7th semester. Yeah, 7 and 8. So you will learn it later on. Okay. So these are the very important terms. So let me a bit give you information because you want to know what is the meaning of this. Anybody know? Let me ask this question first. What is sensitivity? Yes. Anyone? Any student have idea maybe? Now see there, sensitivity means you are doing a test to diagnose a disease. You are doing a test to diagnose the disease. Now what is the chance of true positive cases? True positive cases because of that test. This is known as sensitivity. So sensitivity means true positive cases. So specificity means true negative one. Means if that test is negative, okay, how many cases you can directly rule that out? That is known as true negative. So if certain tests have very high specificity and sensitivity, that's an excellent type of test. So CA 125 is most useful when non-mucinous epithelial cancers are present. Non-mucinous means they are mainly seen in serous type of epithelial cancer. It is elevated in 80% of the patient with epithelial ovarian cancer, but only in 50% with stage 1 disease. So when the lady develops more complicated type like stage 2, stage 3, the chance will be higher. Increased sensitivity is there in postmenopausal women, especially when associated with relevant clinical and ultrasonographic finding. And this is the cutoff value, 30 unit per ml. And in this, the sensitivity is 81 and specificity of 75%. You don't need to remember all these things. Just remember CA 125 or carcinoma antigen 125 can be considered as a very important tumor marker of serous type of epithelial ovarian cancer. All of these are extra information. Now, another type, okay, which was not mentioned before, okay, but we are talking it now, is HE4. Okay, HE4. The full form is human epididymis protein 4. This is a precursor to the epididymal secretory protein E4, and in normal ovarian tissue, there is minimal gene expression and production of HE4. This is mainly present in epididymis, that is in male. Okay. But in ovarian tissue, there is a minimal gene expression and production of this. But as a result of malignancy, this may be present as a tumor marker. So see here, HE4 had the highest sensitivity for detecting ovarian cancer, especially stage 1 disease. And if we combine CA 125 and HE4, there is a more accurate predictor of malignancy than either of them alone. So in clinical practice, often they use this marker, especially to diagnose the ovarian cancer. Okay, so just remember that. Now, another one these days they often do is a ROMI score. just a concept is important here. Roma score, okay, or Roma algorithm. So what is the meaning of this? This is a risk of ovarian malignancy algorithm. Risk of, okay, ovarian malignancy algorithm. So here we again use both of those criteria, HE4 and CA125, to calculate a Roma value. Now there is a formula, okay. I've not mentioned that formula here. If you want to know, you can see some of the site or some textbook and calculate it. This is not really important here. Thus the meaning is important for us. In premenopausal woman, a risk of ovarian malignancy algorithm value of 1.14 or greater indicate a high risk of finding epithelial ovarian cancer, whereas a Roma value less than 1.14 indicates a low risk of finding epithelial ovarian cancer at surgery. So this is why this Roma value is calculated. Whereas in postmenopausal woman, a Roma value of 2.99 or greater indicates a high risk of finding epithelial ovarian cancer, whereas when the value is less than 2.99, it indicates a low risk of finding epithelial ovarian cancer. So this is just one of the point to know whether there's a chance of epithelial ovarian cancer or not by HE4 and CA125 value. Now, what are the other important investigation apart from those tumor marker? One of the important one is ultrasound. There's no doubt about it. Ultrasound is done very early if you suspect the disease. Ultrasound of the pelvis and abdomen as the first imaging test for women with suspected ovarian cancer. And it will give us a lot of information. It tells us whether there is a mass in the ovary or not. Okay. Second, whether there is associated fluid present in peritoneal cavity or not. Perform a CT scan of the pelvis and abdomen to establish the extent of the disease. CT scan is very, very necessary for the staging of the cancer. How far the cancer has spread, CT scan will tell us. It is done if the ultrasound, serum CA125, and clinical status suggest ovarian cancer for the purpose of staging. And always include the thorax if clinically indicated. Of course, we do abdominal CT scan in the beginning. Look for the liver specifically, look for the peritoneum, look for ascites, look for the lymph node, look for the size of the mass, look for the infiltration in the surrounding area. This information is provided by CT scan of the pelvis and abdomen. But during examination, if you believe there is a pleural effusion, if you think lungs are affected, include the thorax as well. MRI routinely for assessing women with suspected ovarian cancer. MRI is also done. Okay. If CT is not that confirmatory, MRI can also be done. Now, how to take biopsy? What is the importance of tissue diagnosis in a case of ovarian cancer? See there. Especially if you have planned for the management or treatment, like you have planned for hysterectomy and bilateral salping oophorectomy, or if you are planning to give cytotoxic chemotherapy, then the lady has to go for confirmed histopathological examination. Then only this type of treatments are followed. Now, how to take tissue from the ovary? Now, one is image guided biopsy. Image guided biopsy, means ultrasound guided biopsy, you can say. So ultrasonography is done, and at the same time we take percutaneous image guided biopsy. Another one is laparoscopic biopsy, which is more popular than percutaneous image guided biopsy, because under direct vision, you can take the biopsy and you can You can see what type of mass is there also. Now, after this, we have reached to the last part of this big topic of the discussion, that is management. Now, how we do the management here? The initial approach to ovarian cancer is to confirm the diagnosis by an exploratory laparotomy. You see this? The exploratory laparotomy may be considered as a part of the investigation also sometimes. Sometimes you don't know what's going on inside, but you strongly believe there is a chance of malignancy. Exploratory laparotomy is done, and you see what's going on there. There may be ascites, there may be a deposition of malignant tissue in the peritoneum, there may be pelvic infiltration, there may be mass there. Okay, this is known as exploratory laparotomy. Then the surgeon decide what to do after good examination there. How many ovaries are involved? 1 or 2? Okay. What about the local invasion? So surgeon will decide it right there. So how to manage stage 1 of ovarian cancer? Okay, stage 1 is known as early ovarian cancer. See here. What is the role of systematic retroperitoneal lymphadenopathy here? Now, perform retroperitoneal lymph node assessment as part of optimal surgical staging in women with suspected ovarian cancer, whose disease appears to be confined to the ovaries, that is, who appear to have stage 1 disease. Now, what's the meaning of this? Now, let me take you back again. Stage 1 disease means the disease is localized in the ovary, okay? But at the same time, we have to perform the lymph node assessment. Who knows? The malignant cells are already there in the lymph node. So don't be very confident, okay? That has to be done. And if it is already involved the lymph node, and if you have not found it out during that exploratory laparotomy, and you leave this lymph node right there, it is a big mistake, okay? Then it can easily go to the other part of the body. All gross disease should be debulk, okay? Debulk means as far as possible, the mass is removed or try to decrease in size. And this is done by a total abdominal hysterectomy, bilateral salpingo-oophorectomy, and infracolic omentectomy. Now see this? This one, we have spoken this term so many times, so students are quite familiar now. Total abdominal hysterectomy means you remove the total uterus from the abdominal root. Bilateral salpingo-oophorectomy means both fallopian tube as well as ovaries are also removed. And along with that, omentum is also sacrificed. That is infracolic omentectomy. Infracolic means below the transverse colon. Okay, whatever greater omentum is there, that is also sacrificed. This is the meaning. Patients with stage 1A tumor, which are well or moderately differentiated and who wish to remain fertile, for example, we have diagnosed them quite early. Okay, some ladies have presented it early in the reproductive age, and they may receive a unilateral salpingo-oophorectomy without compromising the survival. So what is the meaning? You still maintain the fertility there. One ovary is still there. Okay, so probably she can become pregnant in the near future. That is the point. However, the patient must be made to understand that there is a 10% risk of developing a contralateral lesion. So 10% risk is there to develop lesion on the opposite ovary or the ovary which you have left there for the purpose of fertility. Now, it is her decision. We never decide from the patient side. Remember this. You never counsel the patient. It would be nice if you remove both ovary. Okay. So I advise you to remove both ovary. I don't talk like that. I will say, what happens if one ovary is removed? What happens if both ovaries are removed? These are the options. These are the results. And patient party should decide on their own. This is known as informed consent. This is known as counseling. Okay, and many of us are not doing that. Many of us, want to be a hero there, isn't it? We want to take all the credit to ourselves. And if the patient comes later on and we like to say, yes, I have told you that, we want that, but that is a very wrong approach. Always remember this in clinical practice. Okay, this is the principle of counseling. I always give options to my patient, and patient will choose by themselves, and I always welcome, okay, or respect their decision. I never criticize that. This is the way. Let's move on. Now, what is the primary surgery? Okay, in case of advance, that is stage 2 to stage 4 ovarian cancer. The primary surgery which we do there is a complete resection of all macroscopic disease, whatever come across. Okay. Complete resection of all macroscopic disease. Macroscopic means whatever is visible with your naked eye. That is a total abdominal hysterectomy, bilateral salpingo-oophorectomy, and infracolic omentectomy done. Okay, along with that. For example, lymph nodes are enlarged. You remove those lymph nodes. There's definitely whatever tissues are infiltrated, you try to remove that also. Now, what's the role of chemotherapy? The combination chemotherapy is then indicated for patient with advanced disease, okay, like stage 3 or stage 4. See there, 3 or 4, and is also recommended for stage 1C or poorly differentiated stage 1 and any stage 2 disease. Now, all of these are a little bit gone outside. In stage 1C, remember, there is already ascites. There is already infiltration of the peritoneum. So it has already gone out. So in these cases, we start chemotherapy. And these are carboplatin, cisplatin, and Taxol. Okay, so these are just a few of the name. It is unnecessary for well or moderately differentiated stage 1 or 1A or B tumor. Now, let me remind you once again, well differentiated or moderately differentiated tumor means, okay, according to the grading, these tumor are not that bad. Highly malignant tumor is always poorly differentiated or also known as anaplastic. And according to the grading, they are the worst. Now, the last part, what is the use of radiotherapy? What is the use of radiotherapy? Now, see here. Radiation therapy or radiotherapy has been used successfully in the treatment of patient with dysgerminoma. This is very important MCQ question in the exam. Dysgerminoma is a type of germ cell tumor where radiation therapy is successful regarding the treatment. Now, certain preventive aspect, okay, of ovarian cancer, especially if you have diagnosed the family history, means it is running in the family. They are carrying the particular gene in them. If you diagnose that, okay, then what can we do? We can advise them or we can suggest them to go for surgery. And that surgery is bilateral salpingo-oophorectomy by the age of 40, so that there is no chance of development of any ovarian cancer. Bilateral salpingo-oophorectomy. Okay, this is a big surgery, isn't it? But we hope, we believe by the time that lady has already completed her family. By age 40, most of them has already done that. So there is no harm going for this.